My name's Tom, I'm a researcher here at the Australia Institute, and I'm very excited to be inviting a great speaker tonight. His name is Dr. Buddhi Lokuge. I'll read out a quick introduction and we'll get underway. He's a public health physician, author, and co-founder of Every Voice Counts, a social enterprise organisation that designs people-focused programs and promotes change for healthier, happier communities. He's worked as a doctor in Afghanistan, Africa, and the US for Médecins Sans Frontières, and in remote communities in Northern Australia. Buddhi has led international advocacy campaigns promoting affordable medicines and to raise attention to the plight of children with malnutrition. He worked with elders of North East Arnhem to develop a new approach to a devastating neglected disease that has changed guidelines and transformed lives. Buddhi is a medical graduate of Sydney University with a master's degree from Harvard and PhD from ANU. Please welcome Dr. Lokuge.
Hello everybody, thanks for coming. My name's Buddhi, and I'd just like to share a few words today about an issue that's very close to my heart. It comes from a promise I made to an elder I worked with in the Northern Territory over the last few years. I've worked in many different settings, and for many years, in some ways was a bit afraid to sort of enter and work in our own backyard. But I did a couple of years ago, and ended up working with a small group of families who I discovered had suffered like I haven't seen in any parts of the world that I'd worked. I think it's a shame on every doctor in Australia that it was happening today, and so I made a promise to her after working together for a few years that I'd try and do what I could to make sure no other family suffered like hers. But the way it started was like a lot of programs. It was with big intentions and with the idea of eliminating this, in this case, a disease called scabies. I was in charge of that at the time, and there was a great group of people, particularly a young Canberran who's was funding the program. We had NT government involved and Miwatch Health Aboriginal Corporation, and the idea was to wipe out scabies from the Northern Territory. 7 out of 10 kids in the Northern Territory got scabies before their first year of life. On paper, it seemed like a good idea, and hearing about children suffering from this disease, scratching themselves raw, causing sores, and then developing kidney and heart disease that affected them for life was something that I thought as a doctor I should be part of. But as these things happened, as I got closer to Arnhem Land and to launching the program, one of the things I noticed reading about the histories, and that I think everyone who has been involved with this issue has heard about, is ultimately a lot of the disease and the issues that we see are symptoms of lack of control. And Richard Trudgeon is an author who's written about that. And landing in this paradisial island of Galawinku to start the program, there was a palpable sense of people coming and doing things, and Aboriginal people being in some ways witnesses to it. But as things progressed, there was still a reason to see if there was something valuable. We had a team and flexible funding. It's something that I didn't want to give away without really trying to see if there was something valuable. But I remember one day we turned up at someone's house. They had it was as part of a research team. There was a group of researchers who developed a model of treating the region to eliminate this parasite. And I remember knocking on someone's door and coming in to do this scabies treatment, and at the end of the day, this person's speaking in language and clearly upset this elder, saying, this is my house, this is my family, and you've shamed us in front of everyone. It was for me the end of the program, at least as far as I was concerned. And there had been several multi-million-dollar programs in the area. And as I was getting ready to, end my involvement, I went back and started working and sat under a tree and talked to some of the elder women. And you know, they told me, we've been working on this disease for a long time. We need partners, work with us. And what they did was point me to a family and to one particular child who had been continuously sick. So we tried to engage that family. I was in the clinic at the time. And eventually they brought a young child in. When I went through the history, this child had been sick for years, literally from the age of, from birth, continuously sick, covered in sores, had multiple hospitalizations. But the thing that I noticed more than anything was the fact that the health services, each time the mum had come, we'd do the treatments, give antibiotic injections, and when the child came back again sick, they slowly started to blame the mother. You know, you need to have better hygiene, you need to do this, that. And after a while, the grandmother would bring the child in, we'd give the treatment, and the child would get better and then come back again. And eventually Child Protection Services were involved. This was a case of, we were told, parental neglect. And I remember looking at this child and this mother, and you know, she didn't have the look of a mother who was intentionally trying to bring this child to get for treatment and get injected and not get better. But there was a war between us and trying to do something. So over a matter of weeks and months, we slowly just got to know this family, and eventually Mum let us into the house and to sit and talk, and she introduced us to an elder in the house who we discovered had this condition called crusted scabies, severe form of the infection which people have for life in this particular area. This child had been unwell, had been excluded from school for long periods. There had been multiple research projects to try and solve this issue, but eventually when we got to know this mother and this elder, and start working with them, they said, there is a model that we would like to try. It involves the creams that we used in hospital. Can we do it at home? The response normally to this type of condition is an acute outbreak response. We turn up with cars and with insecticide bombs to treat the house to stop the spread of scabies. It's highly infectious, something like 4,000 mites on each gram of skin. And the model that we had been treating it was as we do where we see it in other parts of the country and the world, which is in urban settings in nursing homes, and it's a once-off treatment in an isolation ward. What we found was that many of the patients who had this condition had just avoided health services and gone into hiding. Over time, they developed this hyper-infectious form with millions of mites, literally a disease like leprosy. Health services had no contact with them, and that was causing children to become sick and the community to become sick. With this elder, they talked about a model of care that they had seen, that they had worked, and we trialled that. It took months of using those creams together, and when she became well, she continued that regime, and you know, really it was not very complicated. The model was one where disease where people didn't have an immune protection to scabies, with when they're in an area where there is a lot of scabies, they relapse, they develop hyperinfection, and the cycle continues. So what we did was work with her and developed a preventative model of care. And we started looking for to see what we could do with that. And this elder said to me, you know, a year later, she's back at work, the children are back at school. She said, we have been blamed for this disease for decades. Can you tell other doctors? And I said, no, why don't you tell them? And so we made a video, and she started telling this story about how she first got this condition and how she knew it wasn't her fault and how she had been blamed for it. And over time, that video we shared with other families. They started to come forward, and that model was trialled in 3 communities. Now, instead of Child Protection Services being called, we have a scabies case management team that goes and visits the house and talks and explains in language the model of care. We have now guidelines have changed. So instead of families having to need to ask for treatment, which is what they had to do in the past, it's now the standard, so they can actually access the creams and the treatments that they need to get better. The other thing that we noticed was that a lot of the medicine, the entire pipeline for scabies is a neglected one. Ivermectin, which is one of the drugs, was not registered for scabies in Australia. It's a drug seen as a orphan drug because it doesn't serve a population that has. It's a drug that internationally is used mainly in low-income populations or in Australian very small populations. So there wasn't any research. It wasn't properly registered. Part of the challenge was to create visibility for this condition, and particularly for this condition, crusted scabies. The guidelines have changed and the model of care has changed, but still, ultimately, it was about giving voice. So the first thing when we introduced these new guidelines, this elder came and spoke at a conference and presented the findings. That's the first step to in this condition having better outcomes. But one of the things that I reflected on was we had multi-million-dollar research projects that had tried to address scabies, and this condition was first seen, crusted scabies, in the 1950s. The multi-million-dollar research projects have come and gone. Each time I think we were looking for a magic bullet solution to the chronic problem, and I think that's part of the problem with a lot of the issues. There's this theory that I think is very relevant to a lot of the disadvantage that we see to do with exit voice loyalty, that people have no voice, and so a condition that in Sydney would have a lot of resources and a lot of management, people go without any resources, any attention, and are treated in a way we're looking for quick and simple solutions to chronic problems when in fact it needs long-term support and care. So one of the changes that I hope we left the program was that instead of a 2-year ivermectin mass drug administration, it's one that is gradually building support for a long-term institutionalized approach to scabies. Not as a charity, I think charity has very little role in terms of being involved with healthcare and particularly as delivery of essential services. I think there is a very important role for individuals though in making a difference, and I think one of the things I met with most people who we worked with in the Northern Territory is that they need partners. They need people who can bridge the gap to work to change guidelines that are wrong and blaming them for conditions, or getting access to medications that they need from clinics, but they're not in the current guidelines. So it's one of the things that I've tried to do. I still work in a community called Ramingining, and if anything, I feel sad that it's taken me this long to be involved in this part of our country. The longest surviving culture on the planet, and really I think such an integral part of Australia's culture and history. But I think as an Australian, I was afraid maybe that this was issues that should be solved by Aboriginal people. As a doctor, I went overseas and worked internationally, and I was afraid to do wrong, to do harm, and I'm glad that Sam Prince and his team, got involved with an issue like this, because ultimately individuals, not so much money, but individuals make a big difference. And if Aboriginal people don't have partners who know how to push against unfair laws or rules that are wrong, or clinical guidelines that are not right, then in the long run, we're not being. There's a very important role we can play. So, just to end my talk, I'll read the anecdote. My daughter once said, was at a NAIDOC Day celebration in her school, and she said the students of Aboriginal background were asked to stand in one side, and my daughter quickly jumped up. She had lived in Arnhem Land. She and she jumped up and joined the queue, and I got very afraid. I said, Kalyani, Kalyani, you know, you're not Aboriginal, come back. And I was worried she was appropriating, you know, the title Aboriginal. And then she said to me, but Dad, I speak Yolngamata, I've lived in Arnhem Land, I have friends who are Aboriginal, and it's part of my country's culture. What do you mean? I'm part Aboriginal? And I think she had a point there. Sometimes we're a little bit too hesitant. There are issues that I think we have to solve together, and that's something that I'm hoping that I can inspire through our work with One Disease and with scabies, other doctors and others who have an important role to play as partners to join in. Thank you.